The mission of the Allergy and Asthma Network is to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. This is Lisa Jordan, Project Manager for Allergy and Asthma Network, and it's my pleasure to welcome you to this month's webinar in our 2019 webinar series titled Advances in Allergy and Asthma, brought to you in partnership with the American College of Allergy, Asthma, and Immunology. Dr. Bradley Chips joined us today to talk about guided treatment for type 2 inflammation and give us an update on biologic medication. Dr. Chips received his medical degree from the University of Texas Medical Branch in Galveston in 1972. He was a pediatric resident for 2 years before serving in the Air Force at Ellsworth, AFB in South Dakota for 2 years as a general pediatrician. He then completed a combined allergy and pulmonary fellowship at Johns Hopkins and spent 1 year on the faculty of the Pediatric Respiratory Sciences Division. He has been in private practice in Sacramento since 1979. He is the medical director of respiratory therapy and cystic fibrosis center, Sutter Medical Center in Sacramento, California. He is also the associate medical director of Sutter Community Hospital Sleep Laboratory, which he established in 1984. Dr. Chips is board certified in pediatric pulmonology and allergy and clinical immunology. He is the past president of the American College of Allergy, Asthma, and Immunology. Dr. Chips, we're grateful that you're here with us, and we look forward to all of the information you have to share with us today.
Thank you very much. And on the next slide, you can see my disclosures were companies that I have consulted for and done research for. We're now going to determine the response predictors for the 5 monoclonal antibodies in the U.S. market for asthma and other asthma and allergy-related comorbidities. Examine the specific criteria for monoclonal antibodies, and then just a few words about the limited intervention strategies we have for low T2 asthma. So first, we will work off the GINA step care guidelines for asthma care, which are reworked every year. We have to make sure we review the response to therapy, we assess the patient, and adjust treatment accordingly, looking at the features you can see on this slide. We know that low-dose inhaled corticosteroid with the addition of a long-acting bronchodilator is key to management of these patients. We know that the increased use of short-acting beta agonists is definitely a risk factor for poor asthma control. And we are seeing more and more information about the combination of either long or short-acting beta agonists with inhaled corticosteroid that will help us control asthma. We're now going to look at patients at step 4 and 5 who have a more recalcitrant form of asthma and how a biologic may be helpful in their management. This is brought out very clearly by a paper that I published with a group of investigators in 2012, where we looked at patients age 6 on up to adults. You can see that whether they were using 1, 2, or 3 controllers, that is ICS, long-acting beta agonist, long-acting antimuscarinic, or leukotriene receptor antagonist, they still had a significant burden of healthcare use, even while using these medicines regularly. And you can see that it didn't matter how much medicine we threw at the patient, they still had very significant adverse outcomes. So are there then other things we can do to help make the outcomes better? This cartoon that was just recently published in the American Journal of Respiratory Care and Clinical Care Medicine shows us that multiple mediators are present, cytokines, pro-inflammatory mediators that are released in the airway wall and intraluminally in the airway that can lead then to upregulation of mucus production, smooth muscle hyperreactivity and hyperplasia, goblet cell increase with increased mucus production, airway muscle, airway wall remodeling, and all the factors that are associated with persistent asthma. So the question is, how can we downregulate these factors that are occurring and make our patients' course of their disease less troublesome? So first, let's look at some of the factors that were used to help understand what puts a patient at risk for an adverse asthma outcome. This is from the NHANES study, which is a national study that is done every 5 years, every 5 to 10 years, and looks at on the y-axis, probability of current asthma, probability of asthma attacks, probability of current wheeze, and probability of ER visit for asthma. On the x-axis, we have exhaled nitric oxide, normal being less than 25, and numbers above that being associated with significant asthma activity. The green line are low or normal blood eosinophils less than 150, intermediate between 150 and 299, and high above 300. And you can see for all these outcomes, as the peripheral blood eosinophil count increases, as the exhaled nitric oxide increases, which is a surrogate marker for airway and intraluminal eosinophils, you can see that the percentage of adverse outcomes dramatically increases. And this is a study done by Dr. David Price, 130,000 patients in the UK. You can see that as the peripheral blood eosinophil count increases, the relative risk of an asthma attack does significantly increase. And once you get above 300 cells per microliter, you can see that the adjusted odds ratio of an asthma attack begins to almost logarithmically increase. This is shown in a different way in this German study. The far left are patients who have blood eosinophil counts less than 400 and sputum eosinophil counts less than 3% and normal exhaled nitric oxide on the y-axis. Contrast that to the patients on the far right who have blood eosinophil counts greater than 400, sputum eosinophil counts greater than 3%, and elevated exhaled nitric oxide. These patients on the right had a 3.7 times increased risk of an exacerbation. So very clearly, the eosinophilic signal in the peripheral blood and in the airway predisposes patients to an increased risk for exacerbation. Also, we have shown in the TENOR study that future exacerbations are associated with a recent exacerbation. So you can see the unadjusted increased risk is 6.33, and it is over 3.75 no matter how you adjust for asthma severity. So a previous exacerbation is a definite risk for a future exacerbation, and also is very poorly controlled asthma. Again, in the TENOR study, which I've been involved with for the last 19 years, in children, you can see it's a 6.4 risk, and for adolescents and adults, a 4.9 relative risk odds ratio of having an exacerbation. So the impairment domain is definitely linked to the risk domain in terms of predicting an exacerbation. So let's start now with the first monoclonal antibody that was approved in the United States 16 years ago, that is Omalizumab. This is a study of patients in France, actually. We're going to look at what criteria and what biomarkers do predict response to Omalizumab. And we can see that this is a global evaluation of treatment effectiveness at 4 to 6 months after treatment began. in patients 6 to 17 years of age and adults greater than 18. And you can see that either in the children, which are noted as minors, or the adults, that there was either a 2/3 or 3/4 excellent or good efficacy, with only a small minority having poor or worsening asthma. If you then drill down closer and first look at the eosinophil count, because you'll see that in the other 4 biologics we're going to talk about in a moment, that eosinophil counts are a very important predictor of response to that biologic. In this study, the proportion of patients on the y-axis who had a good response to Omalizumab, partitioned now by blood eosinophil count. On the far left, less than 150. On the right, blood eosinophil counts greater than 1,000. And you can see that the response, that is a good response, was not determined by blood eosinophil count. And this is distinctly different from the other 4 biologics I'm going to talk to you about in just a moment. And you can see again, this is on the y-axis looking at reduction in exacerbations as a rate, a percentage. On the first column, eosinophils over 300, and then partitioning with adding IgE levels less than 75 or more than 75. You can see that there is a slight a better response in patients who have a lower eosinophil count. And this is particularly important because this is in contradistinction to the higher eosinophil counts in the other 4 biologics that predict a greater response. We're going to look, so that was a study from France. This is another study from France that was done just in children. These are 104 children on 6 to 12 years of age who were on qualified for Omalizumab. And this is baseline data. You can see in the darkest bar, 20 weeks in the lighter bar, and the clear bar being 52 weeks. And you can see that significantly better response occurred at 52 weeks than had been at baseline. If you look at that data in a different way, this looks at change in exacerbation rates over the 2 years of the study. At baseline, exacerbation rates per year were approximately 4.25. At 52 weeks, there was a 72% reduction in exacerbations and an 83% reduction in exacerbations at 2 years out. And remember, Omalizumab has the lowest threshold for age. It is now approved down to patients who are 6 years of age and older with a IgE level of 30 to 1,200 in the U.S., 1,500 in Europe, and have 1 positive skin test at least to a perennial allergen. This is shown, I'm going to show you 2 studies now that have looked at Omalizumab in patients in the inner city. This is 419 patients, about 11 years of age, 60% African American, had a 7-year duration of asthma, so 3/4 of their life was spent having asthma. The lung function was still fairly preserved at 92%, 92% FEV1% predicted, and about 3/4 of them had moderate to severe disease. They were treated with either placebo, Omalizumab, for 60 weeks. The important thing is the middle bar in this table. It shows you that in Omalizumab is in the teal color and placebo in the blue. You can see that both the fall and the spring exacerbation rate was definitely truncated. So Omalizumab can result in downregulation of both viral-induced asthma and pollen-induced asthma. And this was particularly shown in the PROS study, where Pre-treatment with Omalizumab was done prior to the onset of the fall season, which is week 38 of the year. 3 groups were studied: those with standard care, those with an increased dose of fluticasone propionate, and standard of care plus Omalizumab. There was little benefit from increasing the dose of inhaled corticosteroid, which was also shown in the STIX trial published by Dr. Dan Jackson last May, but some very interesting data about Omalizumab. The teaser about that was found in the slide I showed you a moment ago, where fall exacerbations were definitely truncated in addition to springtime exacerbations. So what we're going to show you on this next slide is patients who had at least one exacerbation and treated either with step 2 to step 5. You can see the Omalizumab patients they only had 2 injections of Omalizumab before the spring season. They had a 52% reduction in exacerbations. If you take then the patients who had step 5 care, requiring step 5 care, they had a 63% reduction in exacerbations. This is also shown in the patients who had at least one exacerbation during the 8-week run-in period. And you can see, looking at the top bar, the patients who had at least one exacerbation during the run-in period had a significantly greater decrease in exacerbations when treated with Omalizumab. So this drug can be helpful not only for viral-induced exacerbations, but also pollen-induced exacerbations. Let's move on now to the anti-IL-5 inhibitors. These are drugs, Mepolizumab, Reslizumab, and Benralizumab, that work on the eosinophilic phenotype, that is, patients in contradistinction to lower eosinophil patients also do respond to Omalizumab. These are patients primarily with higher eosinophil counts. And these 3 drugs work by different mechanisms. Benralizumab works by combining to the receptor on the eosinophil to directly cause eosinophil apoptosis and antibody-dependent cellular toxicity that kills eosinophils within the first day. The other 2 drugs, Mepolizumab and Reslizumab, work on the IL-5 ligand to help downregulate the duration of eosinophil survival and activation of eosinophils. So let's look at each of these drugs individually now. First, we'll look at Mepolizumab. It was the first anti-IL-5 that was approved in the U.S. It is given as a subcutaneous injection every month, 100 milligrams given subcutaneously every month. And it is a very effective drug. First, looking at change in oral corticosteroid dose, you can see that as much as a 40% decrease in oral corticosteroid dose can occur. Also, a longer time to asthma exacerbations can be seen when Mepolizumab is used. The next drug that was approved is Reslizumab. This is in contradistinction to Mepolizumab. This is an IV preparation given at a dose of 3 milligrams per kilogram IV once a month. And it's approved for in-office and home administration. These studies were done in patients who have, in Mepolizumab, have eosinophil counts over 300. In the Reslizumab patients, these are patients who have an eosinophil count over 400. And both in study 1 and study 2, the adjusted exacerbation rate, that is events per year over 52 weeks, you can see a 50, 59, and 54% decrease in exacerbations when compared to placebo. And also you can see that there was either 130, 90, 110 milliliter increase in FEV1 from baseline at week 52, again compared to placebo. So we see a decrease in exacerbations with Reslizumab and an increase in forced expiratory volume in 1 second. The third drug in the IL-5 space that has been approved is Benralizumab. This is given 30 milligrams subcutaneously each month for 3 months, then every 2 months. So it has a longer interval between dosing after the first 3 injections are given, which is 2 months duration. If you look in patients who on the ZONDA trial were taking oral corticosteroid, the time to first exacerbation compared to placebo was dramatically truncated, and this came about both with every 4-week dosing and every 8-week dosing, because at the time this study was done, the company was trying to decide what dosing interval would be important, but both did show a significant decrease in time to first exacerbation, and also a 75% reduction in oral corticosteroid dose, and over 50% of patients were able to actually completely stop their oral corticosteroid. They started on a prednisone dose of 12.5 milligrams or less. So again, a significant salutary improvement in oral corticosteroid dose. Time to first exacerbation was seen with this drug. Dupilumab is the 5th monoclonal antibody that has been approved. It is approved for patients to decrease exacerbations, and also is the only monoclonal antibody that has an oral corticosteroid indication in their label. It's an anti-IL-4, IL-13 inhibitor, and it is given at a dose of either 200 or 300 milligrams subcutaneously every 2 weeks, as opposed to the others given either monthly or every 8-week interval. Dupilumab can also show a very risk reduction in oral corticosteroid dosing. You can see north of a 70% reduction in corticosteroid dose at 24 weeks of therapy. Also, a significant increase in lung function was seen compared to placebo that occurred. 75% of the improvement in FEV1 occurred within the 2 weeks and continued through the entire 24 weeks of therapy. This fairly complicated slide has some very important information we need to just spend a bit of time looking at, because it summarizes the mechanism of action, indication, dosing, and adverse effects. First, as I mentioned, Omalizumab mechanism of action is anti-IgE. It binds to the receptor on mast cells and depopulates mast cells and basophils. The receptor is depopulated, and it binds IgE. It's approved, as I said, for patients 6 years of age and older. You have IgE levels between, for children, 30 and 1300, and for adults, 30 and 700, and also have a positive skin test to a perennial allergen. There's a dosing table in the package insert for these patients, and it tells you exactly what dose to use. And it's important to understand that the agency does require or suggest that an epinephrine autoinjector be prescribed. The three anti-IL-5s that I mentioned, the two that are approved for greater than 12 years of age, Mepolizumab and Benralizumab, 18 years of age is the threshold level for patients receiving Reslizumab, and it is a weight-based dosing and now has been approved for home administration. Dupilumab is the last one that has been approved, 12 years of age and older. As I mentioned, 200 to 300 milligrams can be given every 2 weeks, and rare hypersensitive reactions can occur, but these drugs are usually very well tolerated. We look then at a table summary of a decreased risk, first of exacerbations. Omalizumab reduced exacerbations by 25%, Mepolizumab 50%, Reslizumab 50 to 60%, Benralizumab 25 to 60%, and Dupilumab 50 to 70%. Lung function for the first two, Omalizumab and Mepolizumab, inconsistent effects have been seen, but Reslizumab, Benralizumab, and Dupilumab all improve lung function. Corticosteroid weaning is a very important part of severe asthma, and Omalizumab really does not have any significant data about that. Mepolizumab does, and as I showed you earlier, is a very significant corticosteroid weaning effect. Not so much for Reslizumab, as they have not evaluated this. Benralizumab, as I showed you, can definitely decrease corticosteroid use by up to 7%, and complete weaning of corticosteroid can occur in 50% of patients, as can be seen with Benralizumab and Dupilumab, can both decrease the need for oral corticosteroid by approximately 50%. So these drugs were all approved, predicated on their ability to decrease exacerbations, and all do decrease exacerbations with different degrees of effectiveness. There's a variable effect on lung function, but all do improve asthma quality of life scores, and the asthma control scores are also improved by all of these medications. We need to talk now about some of the comorbidities that can be affected very positively, in addition to asthma, by these drugs. Let's first look at atopic dermatitis. In the phase 3 Dupilumab trials, using Dupilumab every 2 weeks or every week, the company is trying to decide which interval to use at the time that these studies were done. Using the first, the IGA, which is Investigators Global Assessment Score, you can see up to a 40% improvement was seen compared to placebo with either weekly or bi-weekly dosing of Dupilumab. Also, the eczema area and severity index decreased by 75%. That index here decreasing by 75% was seen in over 50% of the patients. So investigators and patient assessed severity of their eczema significantly improved when treatment was given with Dupilumab. Another drug that is not available in the U.S. market and was just published in the Journal of Allergy and Clinical Immunology last year. This is a Mepolizumab, which is used for moderate to severe atopic dermatitis. It is very helpful in decreasing itching. And this is the visual analog score for itching, pruritus. And you can see that multiple doses have been studied, and all are very effective in changing and decreasing the itching, burden of itching by up to 80%. I can tell you from taking care of patients for a lot of years that itching is one of the major noxious criteria that people are very concerned about when they have eczema. And also the change again in the eczema area and severity index of this drug, you can see decreased by as much as 60%. And this is very important data to show us that both the activity of eczema and the itching from eczema can be decreased by this drug, and hopefully it will come to the U.S. market at some time in the future. And also, sleep disturbance is one of the major concerns in patients with eczema, and this is a change, again, with Mepolizumab in sleep disturbance with a visual analog scale. And you can see with all the active treatments, as much as an 80% improvement from baseline was seen in their sleep visual analog scale score. So again, a new drug that hopefully will come to the U.S. market at some time in the future. The other skin important is urticaria, of course, and we can see that we know that we received the indication for Omalizumab to be used in chronic spontaneous urticaria in 2015. And looking at several of the clinical trials, here on the y-axis is percent reduction in weekly hive scores. UAS is a hive scoring system, and weekly number of hives, and dermatology quality of life index. The gray bars being placebo, the green bars being Omalizumab at 150 milligram dose, and the blue bars being the 300 milligram dose, which I think most of us use for treatment of urticaria at 300 milligrams once a month. You can see up to 70 to 75% improvement in all the criteria that I mentioned in controlling patients with recalcitrant urticaria. Also, we can look and see that under study, we have several other diseases that are being studied now for treatment with one of the 5 biologics that we have. First, eosinophilic esophagitis is an eosinophil inflammatory infiltration of the esophagus that both dupilumab and the anti-IL-5s are currently under study to see if that will be helpful. For nasal polyps and chronic rhinosinusitis, dupilumab just received an indication for the treatment of nasal polyps and chronic rhinosinusitis. The other 4 biologics are currently studying that indication, and we'll have to see who gets the approval for those. In food allergy, both pre-treatment, when oral desensitization is being given, is being studied with Omalizumab and dupilumab. We have to see if that is going to ever be an improved indication. Omalizumab was first studied in peanut allergy and not found to be effective when given just to prevent the progression of peanut allergy. MCAS is mast cell activation syndrome. That is when mast cells are releasing mediators and there are peripheral blood tryptases that are elevated. Omalizumab is currently being studied in mast cell activation syndrome. So all of these other indications for the monoclonal antibodies that are available are being explored at this time and hopefully will come to fruition in the future. So in summary, we can say that guideline therapy is not optimal in 40 to 50% of asthma patients. Some of that is because, as I showed you in the earlier table from the Tenor study, that they just 1, 2, or 3 controllers when given are just not very effective. But also, patients don't take their medicine very regularly, and that leads into increased risk of exacerbation. So, placebo is good when compared to biologics, because if patients do take their medicine, they do get a good response. So biologics are good, but placebo is also. Omalizumab may be particularly helpful in children down to 6 years of age, in chronic spontaneous urticaria, and at all eosinophil levels. In the other 4 biologic, severe eosinophilic asthma, and in severe eosinophilic asthma, Benralizumab is effective in eosinophil suppression, exacerbation reduction, and oral corticosteroid reduction. The anti-IL-4/13 blocker dupilumab is effective in patients with asthma, chronic rhinosinusitis with nasal polyps, atopic dermatitis, and oral corticosteroid reduction. And alarmin, TSLP, which is an epithelial-derived thymus-stromal lipoprotein, tezepelumab is currently under study, and it looks very promising in both Th2 low and Th2 high patients with asthma. We currently have no drug that takes care of low T2 asthma. That remains a significant problem. They can be helped with a long-acting antimuscarinic, and there's also some data, a reasonably new study 18 months ago from Dr. Peter Gibson's group in Australia that shows us that a macrolide azithromycin, when given regularly, may help not only eosinophilic but non-eosinophilic asthma. And there's also a possible role for bronchial thermoplasty in patients with more severe low T2 asthma. So let me stop there and thank you for your attention.
Thank you, Dr. Chips. And we'll now take the question. So our first question is, can we access a copy of the chart that you shared with all the approved biologics? Is there a way that can be accessed by the listeners?
Yes, when the slide deck is placed on the website, then they'll have that reference available and they can download it.
Thank you. And how would you summarize your message for patients that may be listening today?
Well, that very clearly in 5 to 10% of patients who have severe asthma and difficult to treat asthma, that there is hope that other interventions may be helpful in controlling their asthma. And the 5 biologics that are currently in the U.S. market can be very helpful treatment adjuncts in patients who do not respond to conventional therapy, which is inhaled corticosteroid, long-acting beta agonist, and/or long-acting antimuscarinics, leukotriene receptor antagonists, and macrolide antibiotic. If that does not help control their asthma, then they can be have the appropriate test done to see if they would qualify for one of the 5 biologics in the U.S. market.
Great, thank you so much. And then another question is in regard to the dupilumab data, and were the results separated out for asthma versus allergy in that data?
You mean for dupilumab?
Yes, for dupilumab.
Whether or not they were allergic or not was not a major determinant. Major determinant for response to dupilumab were elevated eosinophil counts over 150, in the peripheral blood, an airway compartment eosinophil signal, either with sputum eosinophils or exhaled nitric oxide. If those were present, it really didn't matter whether the patient was allergic or non-allergic. And the same data is also present for patients treated with Benralizumab in a paper that I published in 2017 in the Annals of Allergy.
Okay, great. And there was a question about just wanting to confirm about Mepolizumab being approved for home use. Was that correct?
The 3 that I know of that I think are approved for home use now are dupilumab, of course, Reslizumab. They're all going to get home use eventually. I honestly don't know if Mepolizumab or Omalizumab are approved right now, but okay, they will be soon.
Great. I think that is exactly the clarification we were looking for. And do you have any thoughts or guidelines in particular that help you decide when you're looking at those different monoclonal antibodies, especially when we're talking about Mepolizumab and Reslizumab and Benralizumab? Anything in particular that helps you decide what to choose for a patient?
Well, we want to see what their effect is for comorbidities the patient may have. We need to know the ability to come to the office. So the Benralizumab, which offers an every 8-week interval for dosing after the first 3 shots, would be advantageous in that regard. And all the patients need to have an eosinophilic signal of 300 cells per microliter, plus at least 2 exacerbations in the previous year to qualify for that drug, the anti-L5s. Obviously, the patients who have chronic rhinosinusitis with nasal polyps and atopic dermatitis as a comorbidity, currently dupilumab is the drug that helps to treat those comorbidities most effectively, and also has, of course, a very important role in decreasing exacerbations.
Thank you. And in your opinion, which of the newer drugs would be most effective for nasal polyps and CRS?
Nasal polyps are primarily driven by the IL-4/13 cytokine axis, and so dupilumab would theoretically be a very important drug for that.
Great. And you also noted that some patients were able to reduce or stop oral steroids. Is there data about any patients being able to get off of all their other asthma medications while taking biologics?
Well, that's a very difficult question to answer because for Omalizumab, we've got 16 years of experience, but for the others, we have only 3 or 4 years, 2 to 4 years experience. So we really don't know how safe it is to stop these other drugs. I can tell you, though, in my experience, that once a patient has had 3 to 5 years of therapy, has not had an exacerbation in 2 years, whose lung function is now normal, who's on an inhaled steroid dose that has no systemic effect, that we begin to think about trying to discontinue their their biologic. The way I do that is I increase the interval of their dosing to twice the interval that they're currently doing for at least 2 or 3 doses. If they do well at that time, then I give them the option of stopping. But we're just getting to that point with the other 4 biologics that it's hard to predict that.
Thank you, Dr. Chips. This question comes from a patient. This patient is an asthmatic who has severe asthma, has been hospitalized twice this year, but also with significant lumbar collapse with exacerbation. Would you recommend or consider a potential biologic for a patient like this?
Yes, this is a patient who should be evaluated for a biologic. Make sure we know what comorbidities are present, make sure we know what their eosinophil count is in the peripheral blood, what their eosinophilic signal is in the airway compartment, what their lung function is at rest, and their bronchodilator response. All this needs to be put together in order to make the best, and the ability of them to come to the office or whether home administration is better in order to make a decision about which biologic should be used. This is surely a patient who should be considered for a biologic.
Okay, thank you. And with weight-dependent dosages with biologics, how often do children follow up with physician as they grow?
Well, if a patient who has, in my practice, a patient who has persistent asthma should be seen at least every 3 to 6 months. So you would do that every 3 to 6 months, yes.
Okay. And then another question is that these drugs are relatively new. Do we have any data, or what is the data about long-term side effects or possibility of becoming ineffective over time?
You're talking about for the biologics?
Yes.
Well, again, with Omalizumab, we have the longest track record to look at. And both the Excel study has shown us that for both malignancy, anaphylaxis, and cardiovascular effects, and now the pregnancy registry, that the drug is really very safe and that long-term adverse sequelae are extremely rare. But we don't have that same amount of time to observe these new preparations. But the current 2 to 4 years that we have does not show us an adverse safety signal.
Okay, thank you. And speaking of safety, there's a question about someone who read that a patient on biologics should not receive any live vaccine, and considering a live flu vaccine or anything like that. Do you have information regarding live vaccines? Well, biologics.
The package insert for Dupilumab says not to administer live virus vaccine. I don't believe it's in any of the other 4 package inserts.
Okay, great. And are there any immunomodulators suggested in allergy for mold?
I can't. You're breaking up. I can't hear your question.
Do we have any biologics that are suggested for allergy to mold?
No, none are specifically indicated for that particular problem.
Okay, very, very good. I think that is going to wrap up our questions for today. So thank you, Dr. Chip, and thank you everyone for listening today. At this time, please download the certificate from your control panel. If you have any difficulties, please email us using the link in your email. Please join us next for our August webinar when Dr. Todd Marr will present on vaccine, what we need to know. This webinar will air on Thursday, August 22nd at 8:00 p.m. Eastern, which makes it 7 p.m. Central, 6 p.m. Mountain, and 5 o'clock p.m. Pacific time. You can register for this webinar on our website at allergyasthmanetwork.org. Look for education in the horizontal navigational bar near the top of the page and scroll to webinars. You can also view our archived webinars on this page on the website. Visit our website for quality guidelines-based resources on allergy and asthma. Also access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyasthmarelief.org. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. This is Lisa Jordan for the staff at Allergy and Asthma Network. We hope you have a great and a healthy day as we work better together.